آله وصحبه أجمعين. إخواني وأخواتي الكرام, ladies and gentlemen, السلام عليكم ورحمة الله وبركاته. I'm really honored and privileged to have you coming and attending our scientific session today, and we are happy to have the 41 episode of our IMC Family Medicine Club, which has started almost 5 years ago, and it's continue to provide you with updated informations and data and the state of art of medicine that we can share together. And of course, we have been focusing today on two important challenging issues, which is dyslipidemia and osteoporosis. And as you know, this is one of the two important clinical challenges that we encounter, not only as a family physician, but also as a healthcare problems that has its own burden on our society and community. And when we talk about osteoporosis, it's a silent disease. And unfortunately, it is underdiagnosed, undertreated, especially with a special focus on at-risk populations who are postmenopausal ladies, as well as the elderly. And unfortunately, it relates its bad consequences on those people in terms of fracture and disability and the impairment of the quality of life. And when we talk about dyslipidemia, of course, it's one of the major risk factors for the cardiovascular disease. And unfortunately, it has been there in our community with a high prevalence. Why? Because of obesity and other risk factors that we have as a major component in the features and the profile of our populations. And it has been estimated that majority of our population, the Kingdom of Saudi Arabia, with dyslipidemia, they are suffering. They have dyslipidemia with no clinical complication until the cardiovascular event happens, and then they will be able to identify themselves to be dyslipidemic patients and get treated in our facilities. So without any further ado, I'm very pleased and privileged today to have two of our experts, in fact, in the two fields of dyslipidemia and osteoporosis. They are going to focus and shed lights on the updates and in the screening, diagnosis, and the management of dyslipidemia and osteoporosis. And I'm very sure that this is going to be a very fruitful session for all of us. I would like to thank the Saudi Society for Family and Community Medicine, which shoulder these activities under the umbrella of the society. Special thanks goes to Amgen for giving us this wonderful opportunity. And I would like to thank Fexus also to have this wonderful organization in this new hotel. So we would like to start with the first speaker, Dr. Abdul Hamid Hassan, who is a senior consultant in family medicine and has been engaged in many activities. And we truly believe that he is the right mentor for us, because he has the wealth of information, knowledge, and the quality of care that he provided. And we always strive to learn from him the updates as we go. The second topic will be for Dr. Badr bin Hamd, who is a consultant in family medicine and the chairman of the Family Medicine Department at the International Medical Center. He's going to talk about the update in the management of osteoporosis. So I would like to welcome Dr. Al-Hamid on the stage, and I wish you a very fruitful, wonderful session. And I would like to ask our colleagues who are attending our session virtually to put the questions in the Q&A box, so we'll be able to give it to the speakers at the end of this session. Thank you so much for all of you for attending our session, and thanks for the speakers to accept our invitations. Thank you.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Thank you for attending this session. Thanks, Dr. Asha, for the introduction. And I would like to thank Amgen for the sponsoring this activity. I'm going to talk about dyslipidemia, concentrating on the PCSK9 inhibitors as a class for the management of dyslipidemia. As you know, LDL is a causal factor for dyslipidemia and atherosclerotic cardiovascular disease. But it is not the only causal factor. We know that ApoB is there, lipoprotein little a, hypertriglyceridemia a lot. But till now, the only molecule that we can manage and we can treat and we have definite guidelines for it is LDL. But in the near future, we will have a lot about other abnormalities or markers that needs to be treated. The introduction, because we are going to talk about evolocumab as a PCSK9 inhibitor, it is very important for family physician to know when to prescribe it and how to overcome insurance rejection for this molecule. So this is the CCHI recommendation for prescribing the PCSK9 inhibitor. It should be adult. This is indication for PCSK9 inhibitor to be prescribed, or alone or in combination with other lipid-lowering therapy in case of a statin intolerance. A statin intolerance, you need to prove it in the documentation. You need to have prescribed different molecules of statin, different strengths of statin, and there is statin-associated muscle symptoms, classical statin-associated muscle symptoms that came with the medication and disappeared after stopping the medication. Then you repeat another prescription and the muscle symptoms appear and disappeared after discontinuation. At that point, you can diagnose statin-associated muscle symptoms and intolerance, and you can prescribe PCSK9 inhibitor. The other indication, adult with established atherosclerotic cardiovascular disease not achieving the target with other lipid-lowering therapy in combination with maximum tolerated statin or in case of intolerant to statin. But that you can get approval, as I used to get approval for PCSK9 inhibitors for patient, even for primary prevention, not only for secondary prevention. I remember when evolocumab was introduced to IMC 2017. I was a member of the Pharmacy and the Therapeutic Committee, and the cardiologist insisted that it should be only restricted for cardiologists. But as a member of the P&T committee, I insist that family physician, consultant family physician at IMC should have the privilege to prescribe it. And since that time, we have the privilege to prescribe PCSK9 inhibitor. In other hospitals, I think it is very difficult for them to have the privilege of this. Then in the introduction, this is the blue book from Dr. Hani Al-Ainzi and his colleagues, what they said for dyslipidemia chapter. This is the handbook or the blue book or the primary care manual. How we diagnose dyslipidemia? What is the level of LDL to diagnose dyslipidemia? What is the level? More than 100? Any other number? According to the risk assessment, according to the level of, yes, thank you. According to the risk. So it could be 40, 55, 70, 100, 115. The very low risk person should have less than 116. But look what they said here. Dyslipidemia is diagnosed 160. 160 is very high. 160 was the diagnosis of dyslipidemia many decades before. When I used to tell my patient when we go to Mecca on a camel. At that time, we diagnosed dyslipidemia 160. 160 is a killing level. So no, don't accept this as a level for dyslipidemia. Next, triglyceride, more than 200, I accepted. Some guidelines said it is 150, but it is acceptable. This is very important point. This is Dr. Hani Al-Ainzi manual. It should be fasting lipid profile. Never do lipid profile non-fasting, please. Never. It should be fasting lipid profile. And the 8 hours are very enough. So glucose 8 hours, lipid 8 hours, it could be day and night. He can drink water while he is fasting. So it is very simple, very convenient to do it fasting, lipid. This Dr. Hadi Al-Anzi, he insists that it should be fasting, as I used to do in my clinic. This is the levels, as you can see. It could be 55, and the very low risk is 116. So 116, you should diagnose dyslipidemia. To treat it or not, it is another problem. To prescribe medication or lifestyle, it is another problem. But at least you should inform the patient, engage the patient in his problem. You have dyslipidemia. You have a major risk factor for cardiovascular event, as Dr. Ashraf mentioned. We diagnose it with MI, dyslipidemia. We start the treatment after MI or ischemic stroke. But any person without any risk factor, 116 is dyslipidemia, and it should be diagnosed and managed. Then they said low dose statin shouldn't be prescribed for diabetes. I totally agree. It should be high intensity or moderate intensity statin. Statins contraindicate during pregnancy and lactation. Statin is absolutely contraindicated during lactation, but during pregnancy it is highly indicated. This is the FDA 4 years ago. They mentioned to drug companies manufacturing statin, remove the absolute contraindication of statin during pregnancy. This is the FDA, American FDA, 4 years ago. So statin is indicated in pregnancy only in limited conditions. If there is familial hypercholesterolemia or for secondary prevention, a patient with peripheral arterial disease and got pregnant, for example, you may prescribe statin. Sorry, leave it for the lipidologist. I will not prescribe it. I refer her to a lipidologist to prescribe it. But at least to remove the fear that statins are absolutely contraindicated during pregnancy. This is the FDA, the American FDA, July 2021. Again, still in Dr. Hadi Al-Anzi manual, when to refer. Suspected familial hypercholesterolemia, I will not refer. I confirm the diagnosis, then I refer. Familial history of premature heart disease. This is our patient. This is primary prevention at high risk because he has premature cardiovascular event for his father or his brother. I can manage him. I will put a lower level of LDL and I manage. No need to refer such a patient. Cholesterol 290. Number one, we don't refer depending on cholesterol. We depend on LDL. So remove this. And very high LDL could be managed by us. We can prescribe statin, ezetimibe, PCSK9 inhibitor, and we can manage. So I will not refer a patient with hypercholesterolemia 290 total cholesterol. Triglyceride 800. It is a very low level. I can manage it as a family physician. No need to refer him to a podiatrist or endocrinologist. So I disagree also with this referral for such patients. Intolerance to statin. Who will prescribe PCSK9 inhibitor if not me? So I will not refer statin intolerance. I will prescribe PCSK9 inhibitor. This is very important. Prescribe maximum tolerated statin dose, target 70. This is, I totally agree. Then this is the the most recent updated guidelines from the American Association of Clinical Endocrinology. This year published. They sent me the guidelines a few months ago to get my opinion about the recommendations. And that's why they send me a thankful letter. Thank you for completing the comment on the pharmacological management of the guidelines. Among many experts worldwide, they send the guidelines, like Hypertension Canada, they send me the guidelines that will appear in May 2025. They send me, and now I received this thankful letter from the American Association of Clinical Endocrinology. What they mentioned in the American, the most recent guidelines, this is the most recent guidelines, in adults with dyslipidemia who are on maximum tolerated statin and have atherosclerotic cardiovascular disease or at high risk for atherosclerotic cardiovascular disease, the target should be less than 70. This is not 100% correct because some of them should be 55. there is insufficient evidence to make recommendation for or against user inclisiran because there is no cardiovascular outcome trial for inclisiran till now. That's why it is not recommended by the American Association of Clinical Endocrinology to prescribe. They are insisted only if statin is maximum tolerated or intolerant, PCSK9 inhibitor should be the one to be prescribed. In other words, with dyslipidemia, statin intolerant, you can increase the risk for atherosclerotic disease. They said you can use bempedoic acid. I think we don't have it till now here. In other words, dyslipidemia who don't have atherosclerotic cardiovascular disease and can tolerate lipid-lowering medications, against the use of bempedoic acid in addition to usual care, they insisted on statin and ezetimibe and PCSK9 inhibitor first. In adults with hypertriglyceridemia, from 150 to 500 only, because it is totally different hypertriglyceridemia above 500 and below 500. The molecule of triglycerides in this range is heterogenic. The molecule above 500 contains other lipid markers that will affect the pancreatitis. So if it is less than 500, we are concentrated on the atherogenic effect, and the statin is the first to use, not fibrate or omega-3. If it is more than 500, you need fenofibrate and omega-3. There is insufficient evidence to recommend against the APA in adults with severe hypertriglyceridemia. As I said, it is not for cardiovascular prevention if it is more 500. It is for pancreatitis prevention. If it is from 150 or 200 to 500, it is the atherogenic, and you can use APA or or statin. In adults with hypertriglyceridemia still in the range of 500 who have atherosclerotic cardiovascular disease, they against the combination of APA and DHA. You can use icosapent ethyl only 2 grams twice daily. Usually it is very high dose and it may produce atrial fibrillation, but this is the guidelines. I don't agree with this, but this is the guidelines. There is insufficient evidence to recommend for or against the use of a combination of APA and DHA in severe hypertriglyceridemia. And in adults with hypertriglyceridemia, again in the range of 500, it increased cardiovascular risk against the use of niacin. Of course, it is totally contraindicated. The last recommendation, insufficient evidence to recommend for or against niacin in adults with hypertriglyceridemia, even 500. So niacin is not indicated totally. Recent and future update. From the New England Journal of Medicine, Journal Watch subscription, this paper talking about particle to particle, does lipoprotein little a and LDL cholesterol contribute to atherogenesis? Believe it or not, lipoprotein little a is 6-fold atherogenic compared with LDL. That's why I said we don't have till now except LDL to treat, but in the near future we will have a lot of interventions to manage lipoprotein little a. 6-fold greater risk with lipoprotein little a. We need to measure it at least once in life for all adults at risk. We have it at IMC. I measure it for high-risk patients, and we need to do it. But we don't have anything to do, just we measure it. This paper published in Heart 2 years ago, a Cochrane review, and talking about PCSK9 inhibitor plus statin ezetimibe is very useful for high-risk patients. This is paper about intensive statin treatment in elderly patients. The answer is yes. It should be treated aggressively to a lower level, even if the patient is above 80 years of age. So don't withhold the benefit of treating dyslipidemia even for those high risk patients. Cumulative exposure. We know that the problem with LDL is not only the level, it is the level and the duration of exposure of the endothelium to LDL. So we need the earlier the better to manage this patient. This is the comment of the New England Journal of Medicine. Lifetime burden is very, very important for the risk of cardiovascular event. This paper talking about childhood exposure, again, it said that children with cardiovascular risk factors were more likely to experience serious cardiovascular events at adulthood. So don't withhold the treatment for children with dyslipidemia. If a child is 2 years with obesity, the American Academy of Pediatrics said fasting lipid profile. 2 years of age. You will not treat with drugs at that age, but at least you diagnose dyslipidemia. You can start a statin by the age of 9 or 10 years. And PCSK9 is age 12. So it is very important to look for childhood. Another paper about childhood dyslipidemia, again, this observational study showed that children whose high lipid level resolved early did not have excess cardiovascular. So the treatment, the earlier, the better. This is evidence of, this is the American Heart Association cardiovascular kidney metabolic syndrome. We discussed it many times before. This is the PREVENT calculator, excellent calculator for the cardiovascular risk assessment. It assesses the risk for cardiovascular, atherosclerotic cardiovascular disease, and heart failure. And it assesses the risk within the coming 10 years and 30 years. It assesses the risk of the age of 30 to the age of 80. Excellent calculator. You can Google it, PREVENT calculator, and you can find it. And you can, this is the American Heart Association. This is a comment on the PREVENT calculator showing that it is very important and much, much better than the atherosclerotic cardiovascular disease four-pooled equation of the American College of Cardiology 2013. Another paper about the calculator, as I said, 30 years risk, heart failure, atherosclerotic, and cardiovascular disease from 30 to 80 years. It includes, apart from total cholesterol, smoking, hypertension, diabetes, it includes the social determinants of health, body mass index, GFR, albuminuria, and A1C. So it includes the metabolic risk factors, the kidney problems with the cardiovascular problems. This is inflammation is very important also, and this showed that inflammation was a stronger independent risk factor for atherosclerotic cardiovascular disease. This is the relation between C-reactive protein, LDL, and lipoprotein little a, and it showed every one of these is very independent risk factor for atherosclerotic cardiovascular disease. That's why the European Society of Cardiology, August 2024, they said inflammation very important, and you may prescribe colchicine as an anti-inflammatory for patients with coronary artery disease. This is the lipoprotein little a again, talking about it, and the observation showed that the association, regardless of the presence of the number of other risk factors, lipoprotein little a is very much important. Short interfering molecule, this is, as I told you, within the coming few years, we will have drugs for lipoprotein little a and guidelines from National Lipid Association for lipoprotein little a. Then another drug for hypertriglyceridemia. It is phase 2 trial. And another, this is for the target. As you know, in Europe, the targets are 40, 55, 70, 100, 115. In the state, the target 55 only. I think in the new guidelines, because this was published in circulation, new guidelines from America will go to less than 40, and Europe will go less than 30. Keep this in mind, and you will remember that Abdul Hamid said in Europe it will be 30, in the state it will be 40 in the coming guidelines. Now, we finish with the introduction. كفاية كده يا دكتور عمر؟ الانترودكشن دي عشان الدكتور عمر بس. طيب. Lowering LDL with PCSK9 inhibitor. The guidelines said it is in very high risk. You need to prescribe high maximum tolerated statin and with ezetimibe. Then, if not to target, you can use PCSK9 inhibitor. This is the European Society of Cardiology and European Atherosclerosis Society in 2019. As I said, the target is 55 for high-risk patient. In very high-risk patient, it should be 40 for those who got 2 events within 1 year on maximum tolerated statin, but this patient we are not seeing in family medicine, and the higher level is 116. This is the very high risk, less than 55, and this is less than 40. For some patients, that LDL should be less than 40. This is very high risk patients, less than 55. This is very important recommendation. In patients with acute coronary syndrome, shouldn't leave the hospital except on triple combination. He should be started with statin, ezetimibe, and PCSK9 inhibitor. I remember in 2019, I was invited for a roundtable discussion with 4 cardiologists at IMC, 4 من عندنا. And they invited me to get my opinion. The one female patient admitted to CCU discharged on a statin, ezetimibe, PCSK9 inhibitor from day 1. 1 consultant agreed, 2 consultants disagreed, and they asked my opinion. I told them those who disagree are 100% correct because guidelines said stepwise approach. Statin, ezetimibe, PCSK9 inhibitor. The patient will die before reaching the final indication. The 2 consultants who prescribe statin, ezetimibe, PCSK9 from day 1 in the hospital before discharge are 200% correct, not 100%. Because Dr. Ala Khalil, he determined the level of LDL, and the target is 55. A statin at maximum tolerated dose will never bring the LDL to 55. So why to waste his time and the patient time, why to waste his time and the patient life? It is not the patient time, it is the patient life, and go stepwise. He is 200% correct when prescribing triple medications on day 1. That's now this recommendation comes that before leaving the hospital, such patients should be on triple combination, PCSK9 inhibitor, statin, and ezetimibe. This is the 2023 American College of Cardiology guidelines for preventive cardiology, chronic coronary disease. Again, they said it should be maximum tolerated statin, ezetimibe, and monoclonal antibodies, PCSK9 inhibitor in the hospital. The ADA said the same. You need to add ezetimibe, PCSK9 if the target is not achieved. They said without a lower threshold. So there is no lower level to stop treating the patient. Go as low as you can. Even I remember National Lipid Association, in their guidelines, they said, if we mention the target and you would like to go lower than this target, do it. Forget about us and go to the lower level than our target. So there is no lower threshold for LDL. Moderate or even low risk convincing this benefit. The benefit of lipid lowering therapy, irrespective of age or any other risk factor. to add ezetimibe or PCSK9 inhibitor to reach the target. This is primary prevention for diabetes, because second prevention for diabetes should be 55. So it is 70 or 55. The lifetime risk, the prevent calculator, calculating the 10-year risk and the 30-year risk. The risk within the coming 30 years will be very high. This is to show you that all guidelines recommend the statin ezetimibe PCSK9 inhibitor. This is the goal here, is 40, 55, 70, 100, 116. The use of PCSK9 inhibitor monoclonal antibodies. Guidelines for patients with acute coronary syndrome. Extremely high risk, triple combination therapy, statin, PCSK9, and ezetimibe. Guidelines for patients with diabetes, chronic kidney disease, familial hypercholesterolemia, all recommend triple combination for such patients. The FOURIER-OLE trial, open label extension. This is the FOURIER trial. We started patient evolocumab every 2 weeks or 4 weeks, and all matching placebo with other lipid lowering therapy for 2.2 years. It was terminated prematurely. Then we combined all patients to receive PCSK9 inhibitor. Those who didn't receive PCSK9 inhibitor for 2 years, and those who started PCSK9 from day 1, to see the difference. This is the FOURIER trial. Those on standard of care, the level is 90. Those with FOURIER, the level is 30 milligram per deciliter. 30 milligram. Don't forget this number. Then they bring the patient from here to PCSK9 inhibitor, and they followed for 5 years. See the difference between those who started PCSK9 inhibitor for 7 years compared with those who started PCSK9 for 5 years only. So just 2 years missing PCSK9 inhibitor produced a 15% reduction in the primary endpoint, a statistically significant difference, because they were denied PCSK9 inhibitor for 2 years only, and they used it for 5 years, but it didn't reach the same benefit if you start PCSK9 inhibitor earlier. For secondary endpoint, again, 20% reduction in the cardiovascular death, MI, or ischemic stroke, for only missing PCSK9 inhibitor for 2 years. Cardiovascular death reduction by 23%. So the earlier the better to introduce PCSK9 inhibitor for such patient if they didn't reach a target. Because such patient for 2 years, the LDL was 90, above the target. They will deny it PCSK9 inhibitor. That's why this is the difference. So the earlier, once after 6 weeks of those changes, the target is not achieved, intensify the treatment. Increase the dose of statin or add ezetimibe or add PCSK9 inhibitor. Don't wait for 2 years. As you know, the maximum benefit of a statin is only 6 weeks. You will not gain any benefit after that, whatever the duration of treatment. So after 6 weeks, not to target, go for intensification of the treatment. This is the adverse event, almost the same, no change with PCSK9 inhibitor. This is the sub-analysis of the FOURIER trial. Efficacy and safety, achieving level of LDL with PCSK9 inhibitor. Pre-specified primary and secondary composite endpoints. Cognition was not affected. 10 safety adverse events were evaluated, and all were not different from both in PCSK9 or standard of care. This is the 5 adverse events. As you can see, almost similar incidence of these adverse events. The other 5 adverse. So the 10 adverse events studied in this study showed that it is very safe, well tolerated to prescribe PCSK9 inhibitor with statin ezetimibe. Real world evidence, my last case, this my patient, He is a 68 years old with obesity, fatty liver, type 2 diabetes, hypertension, dyslipidemia. So he has a cardiovascular kidney metabolic syndrome because there is obesity. We know to diagnose the syndrome, there should be obesity, then any other thing else. So this patient, he came to me in 2021. And he said in the clinic with his wife, I have some epigastric pain. I told him you should go to ER at once. He said no, I had a breakfast, full and tamiz, and this is from full and tamiz, it is not a serious problem. While discussing, he said again, the pain is increasing. I told him you should go to ER now. He said no, I will take the medicine, I will take Nexium and I will be good. He went to the pharmacy, I told his wife he should go to the ER, but he is refusing. He went to the pharmacy to collect his medications. In the pharmacy, he called me. Doctor, I have severe pain, I need help. I jumped to the pharmacy, bring a wheelchair, call Dr. Shireen in the ER, I am bringing an acute MI, please prepare your team. Within 3 hours, he was on the table with Khalid Tammam for stenting. So, leaving him with LDL at these levels, with diabetes, with hypertension, with obesity, is a criminal event. This is not, shouldn't be happen. That's why I went for him different statin. By the way, you see A1C, he didn't die from hyperglycemia. He will not die from ketoacidosis. He will die from cardiovascular disease. So dyslipidemia, hypertension should be managed very aggressively in such patients. I tried with him all incretin-based therapy with all other diabetic medications. He cannot tolerate any of the incretins. Why? Because he is eating too much. So he developed nausea and vomiting, so he stopped all the, I tried with him all the incretin therapy we have. But I started him on statin ezetimibe. Till this time, we didn't achieve the target, so I started him on evolocumab. You see the level in March, 17. What do you think? What should I do in March to stop PCSK9? Dr. Omar, continue. Excellent. I remember in 2019, I have a patient coming for me, treated with Dr. Walid Hassan, but he was in the state, and his LDL was 18. I re-prescribed, Dr. Walid was in America, I saw him, I refilled his PCSK9 inhibitor, evolocumab. When Dr. Walid came from the States, I told him, your patient so and so, I continued. He said, excellent. We shouldn't stop PCSK9 inhibitor. So that's why I told you in Fourier, the level was 30, and they continued for 7 years on the level of 30. So don't be hesitant and continue PCSK9 at such level, and don't stop the patient, don't deny the patient the benefit of the lower the better, or the lowest the best. So he started atorvastatin and developed MI, and we intensified the treatment for atorvastatin ezetimibe 1040. He didn't reach the target. We started, he was on dual antiplatelet, and I started him on evolocumab, and he is now at target, alhamdulillah. So in summary, long-term use of evolocumab with median follow-up of 7 years was safe and well tolerated. Earlier initiation is much better than waiting for 2 years, like the difference in Fourier-Olay trial. These findings argue the earlier initiation. PCSK9 improves cardiovascular outcome in patients with established cardiovascular disease. Long-term safety is confirmed. As I showed you, 10 of the side effects were almost similar for 7 years. Take-home message, international guidelines support the concept of the lowest is the best. Goal should be achieved very low level of LDL early on maximum cardiovascular benefit. Urgent need for paradigm shift in the management of such patients. Monotonic relationship between evidence of LDL and major cardiovascular outcome is very known. Thank you.
Thank you so much, Dr. Al-Hamid, for this wonderful, fatty presentation that had a lot of information, a lot of updates, and a lot of concerns, you have raised with your presentation. And I think this will be enlightening for all of us, to change the style of practicing, dealing with our patients with dyslipidemia. Because of the time, I would like to invite our second guest speaker, Dr. Badr Al-Hamd, who is a consultant in family medicine, and he's the chairman of the family medicine department. He's going to talk about osteoporosis and updating the management, another important topic for all of us as a family physician. I'm very sure that this is the area of expertise of Dr. Badr, so he will enlighten us with a lot of updates and surprising data. Thank you so much for being with us here. Thank you.
Okay, thank you so much, Dr. Ashraf. Thank you so much for organizing committee and for Amgis for sponsoring this event. So inshallah, we'll not take long. I know it's late, and we'll try my best, inshallah, to be practical as much as we can, inshallah. Okay, so to start with, osteoporosis is a systemic skeletal disorder that increases the individual risk of fracture, consequently affecting morbidity and mortality. And this is the main important point why we're talking about osteoporosis. And it is increasing in the kingdom, and that's since 2019. And since that time, okay, the Society for Osteoporosis, Saudi Society of Osteoporosis, they updated their guideline. That's why always we are updating ourselves from local guideline and international guideline. As we can see here, almost 34% of postmenopausal women, they have osteoporosis, and after hip fracture, 27% die within 1 year in Saudi Arabia. So we are talking about high impact, and our role as a family physician is very high. The cost as well is very high. The cost for medication, the cost for hospitalization. So we are talking about an important disease, and as a family physician, we have a great role in preventing all of this. So I recommend to update yourself from Saudi Society of Osteoporosis, and if you want to go for British guideline, you have the National Osteoporotic Guideline. So I will not go in detail about the causes and risk factor, we know it, but just remind ourselves about the big headlines of causes of osteoporosis. Lifestyle, of course, this is our area as a family physician. Please, until today, I was advising my patient, please go and do resistance exercise. Okay, don't walk, jogging, amshu. All of this very important, emphasizing every time on lifestyle modification, stop smoking, adequate physical activity, and so on. Non-modifiable risk factor, this is not in our hand, but we should be considered as well. What about genetic factor? Of course, we have multiple genetic factors. We should consider this as well. Drugs. Okay, as a family physician, we are dealing with all drugs. So please review the whole medication, the whole list of medication for your patient. Of course, even me, I cannot memorize everything. By the way, I'm keeping this presentation in my desktop. Every now and then, I'm reminding myself and my patient about it. The most important medication is steroid. Just until today, I'm asking my patient, she is an asthmatic patient, and she was receiving steroid in the past 10 years, high doses. So she's at high risk. So we should keep this in our mind. Immunosuppressant. Just today, I have a patient. She is a 50-year-old with breast cancer, and she received immunosuppressant. So we should keep this in mind. So all of these medication considered as a risk factor for our patient. Inflammation. They are talking now more and more about inflammation. Dr. Abdul Hamid talked about inflammation. You will hear it in the coming 5 years. More and more, they will talk about the inflammation and the importance of inflammation in developing many diseases. COPD, Cushing syndrome, eating disorder, hyperparathyroidism, IBD, and so on, autoimmune disease, dementia, insulin dependent, so on. So, is it only vitamin D deficiency? Do we have more? Do we have more? Yes. But there is one missing. What is it? One missing. It's not common. It is rare. We are not seeing this anymore. Okay, rarely. I saw one patient in the last 10 years. So, not liver disease, sorry. not underweight. Poliomyelitis, believe it or not. 6 months back, I saw a male patient with poliomyelitis with severe osteoporosis, misdiagnosed. So this is the case, 70-year-old male patient, known case of poliomyelitis. He came to my clinic in IMC in wheelchair. He has weakness mainly in the right side, okay? In addition, he is a case, by the way, hyperparathyroidism, full of risk factor, hypertension, diabetic, ischemic heart disease. He was complaining of the left hip pain, not the right, left hip pain. So this was his BMD. You will not see things small, but minus 4.4. especially in the right femoral. So the weak side, which is the right side, it was minus 4.4, but the pain was in the left side. So CT scan was done for him. He has severe osteoarthritic changes in the left side. That's why he is having the pain on the left side, but he is having severe osteoporosis, and there is report, and the advice was, this could be a wrong assessment because you have poliomyelitis. That's why your BMD is not correct. This information is not correct. We still depend on BMD even in case of poliomyelitis, so we are dealing with a case of severe osteoporosis, and the patient should be on treatment. So our role as a family physician is to screen, assess, and manage. But the question, how to screen? Is it only by BMD? Yes, we are doing the DEXA scan, but still we can do calculation with FRAX even without BMD, and please take detailed history and for the risk factor. So this is a FRAX. How many of you are familiar with FRAX? Raise your hand. MashaAllah, that's great, MashaAllah, tabarakallah. So the new thing that we have the flag, we have the Saudi Arabia and the Middle East, most of the countries of the Middle East involved already. So after using the FRAX, even without the BMD, you can classify your patient as low risk, intermediate risk, and high risk, and this will help you in deciding, should I prescribe, should I order BMD right now for my patient, or I can postpone it if the patient is low risk, especially if the insurance reject more once or twice. I will skip this. So this will help us, the screening in this way without BMD, to screen more patients in short time, decrease the cost by minimizing doing BMD for every patient, to overcome obstacles related to ordering BMD, especially insurance. So at least we have another tool other than BMD. So how to screen? Of course, we need to use the BMD, but the most important message, please don't forget this. Ideally, don't rely on other DEXA scan. So DEXA scan from another hospital, they are using different software. So please don't compare it with your DEXA scan. You can have some insight about it, you can have some idea, but please, you need to follow their patient with the same center. So what about the recent guideline about screening? All Saudi women and men aged 60 and above should be screened. Women above 40 with risk factors should be screened. Premature menopause, prolonged secondary amenorrhea, those on long-term steroid, adults with primary hyperparathyroidism, those with radiological evidence suggesting fragility fracture, and so on. All of these are high-risk people or high-risk individual candidate for screening. So if you forget everything in my presentation, please remember this. T-score, is it the only tool to assess risk factor for fracture and decide about the management? So some they are saying no, some they are saying yes. So we are looking at T-score, is it high or low, and we will decide about our management based on this score. Believe it or not, I have a patient today, she considered as osteopenia, but her major osteoporotic fracture was 10. And she is almost 70, and previous history of fracture, and the past 10 years she was taking steroid, and she has first-degree relative osteoporosis. Should I treat? Yes, I should treat. If I decide my management according to T-score, so I will say you are osteopenia, so the only thing I can give you is calcium and vitamin D. So we are missing some cases. So why is it important? Please don't assess and treat based on T-score. Use the FRAX assessment. This will help you in classifying your patient, and each classification has different management. It also depends on your clinical judgment. So this is the second or the most important slide, okay? So you have 5 things to think about once you want to decide about the classification, about the management. T-score, TBS, which is trabecular bone score, risk factor and secondary causes, 10-year probability of hip fracture, 10-year probability of major osteoporotic fracture. All of us, we know the classification of T-score, so I will skip this. What about the updated diagnosis? So the operational cut for the diagnosis, as we said, as we know, T-score less or below minus 2.4, but also osteoporosis is considered for low trauma spine or hip fracture, T-score between -1 and -2.5 with fragility fracture, and high fracs based on Saudi specific threshold. So please update yourself about the last one. So this is the trabecular bone score. It is a tool used in evaluation of osteoporosis as well. And this is the classification. We have the T-score classification, and please memorize the TBS classification. And I had a patient yesterday. The T-score is almost -2, but the TBS was 1.1, degraded bone. So it shifts the patient from moderate risk of fracture to high risk of fracture. It's really make a big difference with our patient. So fracs, we are familiar for fracs. It is based on clinical risk factor and bone mineral density. So it's very easy. You will Google it. By the way, it will not take more than 3 minutes or 2 minutes in the clinic. I'm doing this every day. It's so practical, and you can use it simply. So this is the first page. Then after that, you will go to the calculator tool. Then after that, you will choose the country based on, please, the ethnicity. I have a lady, she is Saudi, but her root is Jordanian. Another lady, she is Tunisian, she is Canadian, but the root is Tunisian, okay? So please go to the root. We are talking about the ethnicity. So now Saudi Arabia is included, so you can choose Middle East, and after that you can choose Saudi Arabia, for example, and then after that you will fill everything. Of course, before filling everything, don't forget, here you will change to minus T-score. You will fill with the T-score of the femoral neck, calculate, and after you press calculate, you will find this page. So for example, this patient is having major osteoporotic fracture of 13. And after that, this icon was added almost less than 2 years, adjust with TBS. So once you press adjust with TBS, you will write the TBS. The TBS now is available in the BMD. And this patient, for example, the major osteoporotic fracture was 13. After adjusting with TBS, it increased to 17. So it makes a big difference in the management of our patient. So I want to be more practical in 3 steps only. Okay, so the first step, look at the T-score, match it with the TBS, classify your patient. Second step, you can plot the 10-year probability major osteoporotic fracture and the hip fracture according to the age. This is from the British. You can use anyone, Australian, Canadian, the Saudi one, you can use anyone. I'm using this, it's easy. Then after that, you can assess the risk of your patient. And now we have all the parameters, T-score, TBS, the 10-year probability of major osteoporotic fracture, the 10-year probability of hip fracture, and we have in our hand the risk factor. So the final step, this step 2. Step 3, classify your patient, low, moderate, high, very high risk. And now they make it like low, high, and very high risk. So for the low risk and for the very high risk, okay, always, we'll start with lifestyle, but the clinical judgment come here between the moderate and the high risk. Should we start or we shouldn't? Okay, so this clinical judgment depends on the previous parameters. So lifestyle, I will not go in detail, but you should memorize this. Adequate calcium, vitamin D, please, optimal dose. You need to reach the optimal dose of vitamin D. Exercise, don't say to your patient, you need to do exercise. Like, okay, doctor, the lady today, I'm walking every day, 14 kilos. This is not enough. Resistance exercise or jogging, okay, all of this very important. Really, it make a big difference for your patient. Smoking cessation, a major factor. Please don't forget to ask about all type of smoking. Counseling on fall prevention, avoid alcohol use, and of course, counseling about diet. And when we are discussing with Dr. Omar today, the association between celiac disease and gluten, okay, sensitivity and osteoporosis, and there is a strong association with both. Moving to the pharmacological treatment, please don't forget to measure the calcium and vitamin D before prescribing your medication. Practically speaking, we have two main classes that we are using as a family medicine, as internists: denosumab mainly, okay, and bisphosphonate. This is in the antiresorptive. And in the anabolic, we have the parathyroid hormone analog and romosozumab. And this is our core talk today. So antiresorptive drug will inhibit osteoclast activity. Anabolic will stimulate osteoblast activity. Most drugs fit into one or another, but romosozumab has a dual action, as we will discuss in the coming slide. So how to choose the medication, the appropriate medication for your patient? As we know, we have more than 10 criteria, like the efficacy, safety, authority, the cost, and of course, your judgment, your clinical judgment about the osteoporotic severity. The message here: any available medication can be the first line according to your clinical judgment and according to the availability and affordability of the medication. So secondly, I always keep this page. I like this page in my desktop, so it make it easy for me. So easily you can classify your patient to low risk, high risk, and very high risk according to all the parameters. For example, a high risk patient is having a prior fracture, T-score less or equal to 2.5, and T-score with fragility fracture between 1, -1, and -2.5, and so on. So this will help you a lot. If you don't want to use this, you have another page. Very nice, simplified, and it's very nicely illustrated and can be discussed easily with your patient. So we have more than 10 indicators for high-risk patient, and you can decide whether your patient have 1 or 2 or 3 of this, and then after that, it will help you to choose your medication. So how to be practical more? If you have a high-risk patient, now we know the criteria of high-risk patient, okay, according to the 5 criteria. So still the first line is bisphosphonate or denosumab. If the patient is very high risk with fracture, with T-score less than 3, -3, and so on, still the anabolic comes on the first line. The Saudi Society make it easier and easier, and you can find this in the Saudi Society guidelines. So here comes all the category of osteoporotic patient. For example, even osteoporosis in men, okay? And this is the first line therapy, and this is the alternative or second line. So even osteoporosis in men, you can start with oral bisphosphonate, denosumab, or romosozumab. Nobody will say wrong or right, but who will decide? You, according to the class and severity. Oral bisphosphonate, I will not go in detail, but you should consider the contraindication. The main contraindication is esophageal disorder, inability to follow the dosing, chronic kidney disease, and so on. Denosumab, considered as a human monoclonal antibody, as we said, it inhibits osteoclastic formation, and it is an injection every 6 months, and it's effective for those with moderate and high risk patients. And our talk today, which is romosozumab, which has a dual effect. So it decreases the bone resorption, and it will increase bone formation. So it's an amazing drug that has this dual effect. This is the indication. Every now and then, I'm reminding myself about the indication. Recent fracture within the last 12 months, fracture while on osteoporosis therapy, multiple fracture while on drug causing skeletal harm, T-score less or equal to -3, a very high fracture probability. Total, of course, I didn't see this in my life. A major osteoporotic fracture 30, I didn't see it in my life. But 10, 15, yes, I saw it, and so on. So these are the indication. So why romosozumab? We have different or more than 3 studies. So it was studies in nearly 2,000 women with postmenopausal osteoporosis. I will talk about some because of the time. How many minutes I have? 5 minutes. In 5 minutes, I will finish. So I will concentrate on frame. So the all study, the arch frame and structure, they are comparing romosozumab with placebo, with oral bisphosphonate, and with parathyroid hormone analog. And they are seeing and comparing the BMD improvement and the decrease in the probability of fracture. So here, as we can see here, they randomized the patient into 2 groups, placebo and romosozumab, for 1 year. Then after that, both groups shifted to denosumab. So there was almost 73% decrease relative risk the reduction in the vertebral fraction. And after converting, after 1 year, romosozumab to denosumab, there was still, as Dr. Abdelhamid said, in the lipid, after you stop and shift, okay, still there is always the impact, the positive impact of the previous medication in the previous 12 months. Still we have a reduction of 75%. What about the improvement in the BMD? Almost we have 13% improvement in the BMD in the lumbar spine for those who use the romosozumab for 12 months and after that continue even when they converted to denosumab. So the effect is still there even for 2 years. What about the total hip? Even the BMD, almost there is improvement in the BMD by 6% for the total hip, even after 12 months, as we can see up to 2 years, even after shifting the patient to denosumab. So it is a great medication. Again, in the femoral neck, there was an improvement by 5% in the femoral neck. So it's a great medication, and you can go and discuss again and read again about the structure, about the arch. Because of the time, I will not go in discussion about this. But I will go to a very important slide that compare the romosozumab with others. As we can see here, in the first here, romosozumab in comparison with other available medication, okay, still it is the highest powerful medication that improve the BMD in the first year in comparison to other medication. Of course, you need to select your patient. Romosozumab is for high-risk patient and for those with very high-risk patient according to your clinical judgment. This is the safety profile or the major side effect. Of course, it's mainly a cardiovascular side effect. That's why you need to select your patient carefully. The dosing is easily. We have 1 dose with 2 injections every month for only 1 year. The main contraindication, hypocalcemia and patient having stroke. If you stop denosumab, please, you need to start another anti-resorptive agent like alendronate to avoid decline in BMD. Second mistake, so patient will start it on denosumab for 1 year, 2 years. The BMD is improving and improving and improving. So the physician will tell the patient, you are improving, so you need to stop the medication. Once you stop the medication, she will have decline in BMD. And the last message, it is not recommended until now to combine anabolic and anti-resorptive together. So how frequent should we monitor our patient? Every 1 to 2 years according to your clinical judgment and according to the BMD improvement. When should we refer the patient? If there is declining, the patient keep declining, or if there is fracture during treatment. And these are the cases that should be referred. One of the cases is patient with secondary causes and patient with chronic disease. These are the most important 2 categories that should be referred to osteoporosis specialists. Take-home message. Apply the information from DEXA scan, T-score, and TBS and history into FRAX. Choose the appropriate country. Calculate the 10-year probability for the hip fracture and the major osteoporotic fracture. Classify your patient risk factor. And finally, match the risk factor and severity with the most appropriate treatment. Thank you so much.
Thank you so much. Thank you so much, Dr. Badr, for this informative presentation. And I would like to welcome, invite 2 speakers to be on the stage here to start the Q&A sessions. And it seems that we have more than 1,000 attendees here with us virtually. And I have received some of the questions, but we will open the floor now for the physical attendance. Any questions from the audience here? I can see hands. Abu Rida? Right. طيب, okay, so I will just highlight the questions as it is. This is a question from Dr. Muhammad Tahir. For you, Dr. Abdul Hamid, statin effects on the muscles, is it reversible or irreversible? And what are the techniques that you can, adapt to minimize this kind of side effects?
Thank you. It is well known that the statin will produce statin-associated muscle symptoms, including pain of the major muscle groups, not only small or hand or feet. It should be major muscle groups, and it is reversible after stopping the statin. And if it is repeated by changing the molecule, you diagnose statin intolerance and you don't prescribe it anymore, and you can go for PCSK9 inhibitor and ezetimibe or bempedoic acid, or when it is indicated, we can add other drugs. But it is reversible after stopping the statin.
Okay. Dr. Badr, thank you so much for the nice presentations. In fact, you have highlighted a lot of things, but we just would like to emphasize on when we should begin osteoporosis screening and follow-up in low versus high-risk populations.
So follow-up, thank you, Dr. Raja, for this question. So it depends on your clinical judgment, mostly on those patients who are on treatment. At least you should follow up, and especially high-risk patient, moderate to high risk, especially female patients should follow every year. This is the recommendation. Okay, you can postpone it like 1 year and a half, not more than 2 years, okay, in low-risk patient. So like, for example, for today, I have a patient with normal BMD. She is very low risk, okay, and she asked this question. I told her, come after 2 years, okay. Another patient today, okay, she's 50-year-old with on hormonal therapy. She has breast cancer, okay, she is underweight, okay. I told her, you should come every year. So it depends on the patient and your clinical judgment.
Okay, how about treating osteopenia rather than osteoporosis?
Most of the cases of osteopenia, you need, again, to reclassify it. Is it low-risk osteopenia? Is it high-risk osteopenia? Again and again, it's about the risk factor of your patient. So mostly the range is between, practically speaking, between 1 to 2 years, not more, not less.
Okay. Dr. Hamid, when we should start screening for dyslipidemia in asymptomatic adult and children's? You have said it, but if you can rephrase it again.
Yes. According to the United States Preventive Services Task Force, it is 20 years of age. But for children with obesity, the American Academy of Pediatrics said 2 years. By the age of 2 years, you measure fasting lipid profile and start healthy education. Huh?
And you treat at the age of
Treat
6?
at the age of 9.
9, okay.
But from the age of 2 years, you need to spend at least 26 hours face-to-face health education to the parents,
Okay.
to correct the dyslipidemia and the obesity.
Okay, perfect. طيب, Dr. Badr, is the FRAX tool accurate and culturally appropriate for the Saudi populations, and should we adjust the threshold?
Yes, and this is my message. Yani, unfortunately, all the report until today, the lady has major osteoporotic fracture of 10. In the report, when I recalculate her FRAX, it was 4. And I have many examples. So the problem that the software and the BMD in all hospitals are fixed software, and it depends on certain countries. That's why you need to recalculate according to the ethnicity of your patient. And this really will make a huge difference in your management. Is it accurate? Yes. All the countries worldwide, nationally and internationally, they depend on FRAX. Yeah, and FRAX is not a tool, one tool. It depends on all the tools that you are collecting from your patient.
Yes. Okay, thank you. Dr. Abdul Hamid, what is the most accurate lipid marker for the cardiovascular risk? LDL cholesterol, non-HDL cholesterol, ApoB, and you were mentioning about
Lipoprotein
little a.
Yes.
So lipoprotein is 6 times, as you said.
Atherogenic than LDL. But we don't have drug for it, so we forget about it for the time being.
Okay.
You remember after a few years that Abdul Hamid said it is very important, but for today, it is only LDL. That's why I used to measure LDL and triglycerides only, because these are the ones to be tackled, and these are the ones that we have medication and intervention to treat it. HDL is very good, but useless. Total cholesterol is also not important. I used LDL and the triglycerides only.
Okay, so just let's talk about a different topic now, which is a very important one. The opposing informations that we are receiving by the social influencer that statins are a big cheat. It's because of, superimposed by the pharmaceutical companies, and we are the one who's prescribing it for that sake. So how do you comment on this statement, and what is the action do you think that we have to do as a family physician and as a healthcare workers and the decision makers, to compete or to defeat this kind of wave?
Thank you very much. Next week we will have journal club and we will discuss this paper with the resident, inshallah. I invite you all to attend.
Yes, very good.
LDL and the statin. If the regulatory bodies, the FDA, was pushed from pharmaceutical company to mention LDL is very bad and the statin are very good. We accept it. Major authorities like American College of Cardiology, European Society of Cardiology had been fooled by the drug companies that statin are very good and LDL is very bad. Doctors had been fooled by the drug companies that statin is very good and LDL is very bad. What about insurance companies?
Yes.
They are paying millions and millions of dollars every day for statin. If they are sure that LDL is very good and the statin are very bad, they will stop prescribing it. They stop covering it.
They will save money.
Yes, they will save money. So once insurance companies agree to prescribe or dispense statin, it means it is very important, very effective, and the LDL should be go lower. Even now they accept PCSK9 inhibitor, 1,000 riyal per injection to lower the LDL. So LDL is very bad. Statin and other lipid-lowering drugs are very important, very effective.
Okay,
I think
thank
this
you.
could be enough.
So what is our role, Doctor?
I want to add one point. So usually when I describe the medication for my patient, so I don't say that statin is a medication, it's anti-lipid medication. I told them that statin is the medication to protect your heart directly. So really, we need to change even the terminology, the beliefs. The patient will ask you, really, it will protect my heart. It's not only for cholesterol. Yes, it will protect your heart. But even the way you are conveying or delivering the message to your patient, it makes really a difference. Just today, very highly educated PhD patient, okay, he said to me, Doctor, I stopped statin. My LDL was 200. I was in France. I started to use thyme leaves, and really it works. And I was advertising this even for doctors, by the way. I told him, no problem, you can use it. But don't forget your medication that protect your heart. Yeah. There is no contradiction here, okay? But it's how the way how you convince your patient how to deliver the information. Don't be on the side of pharmaceutical company. No, it's the evidence. The evidence is there, okay? And even educated or not educated patient, you can convey the message in very simple way and describe it even by numbers, even by examples. Okay, 2 days back, I will end by this. I have a physician, a consultant, who wasn't convinced about taking statin, and he is having familial hypercholesterolemia. Yeah. 2 years back, he has a heart attack, and now he has 3 stents. So this is the way how should we talk to our patients.
So this is the interactions with the patients in the clinic, but what will be our role across the broader geographical areas to tackle the problem at the level of the community? As a physicians, as a society. And I think there should be some kind of actions that has to be taken. And this will take us to our real role as a family physician. We are not a practicing physicians, and we are not just only engaged in learning and teaching, but also we should be a medical social influencers. So having this kind of data and evidence-based, we have to be there in the social media to counteract this misinformation that has been spread across the nations and across the community, and it creates some kind of resistance, to the treatment and subjecting our patient and the community for the worst outcome that ever can happen.
That's why we should be a change agent.
Absolutely.
An agent for change to the better health of the community.
Absolutely. Yes. So this is the hope that we are looking for. Dr. Badr, what is the optimal durations for therapy and how do you manage drug holiday safety?
Yes, simply you need to know the medication that you are prescribing. Each medication in each class, it has a specific duration. Okay, for example, bisphosphonate, even oral bisphosphonate, each one has a specific date. For example, duration. For example, denosumab, which we are talking about, denosumab, romosumab is very clear. Romosumab, which is our core talk today, it's only for 1 year, not more than that until now, for only postmenopausal women. Denosumab was 14 years, now more than 10 years. Other oral bisphosphonate for 5 years, then you should stop and reassess your patient. It depends on the medication that you are using with your patient, and it depends on the evaluation and assessment of the BMD every year.
Yeah. There is a question from the online attendees, Dr. Najwa Muhammad. She's saying, she has a very nice question. In fact, the role of vitamin D, not in osteoporosis, in hyperlipidemia. So, if there is any evidence?
I am not aware of any evidence, but I am aware that everything worldwide is happening because of vitamin D deficiency. Okay. Even the new taxes from the Trump is due to vitamin D deficiency. Ukrainian war is due to vitamin D deficiency. Everything is vitamin D deficiency, except dyslipidemia.
I believe, Dr. Ashraf, the hot topic now is not vitamin D. The hot topic really is the correlation and association between inflammation and dysbiosis. Dysbiosis, which is the imbalance of the bacteria in the colon, okay, which really can cause serious medical problems. It can cause cardiovascular disease. It can even cause depression and so on. So this is the hot topic, okay? Vitamin D could participate, could contribute, okay, but still we don't have a very strong correlation with cardiovascular disease or others. But we should think about the core, which is inflammation.
Okay, thank you so much. Before we end, I would like to ask the guest speaker to give us just one single statement as recommendations in dyslipidemia and in osteoporosis to enhance our competency as a primary care physician in managing these two clinical conditions. Just one statement. Mm-hmm.
The lowest, the best. Keep intensifying the treatment till reach the lowest level of LDL.
Thank you so much.
Don't forget to calculate FRAX, break the ice, prescribe the new medication. We are competent, we are confident family physician, okay, and we should lead the osteoporosis management.
Okay, with this wonderful statement, I would like to end the sessions by thanking our guest speakers, and I would like to hold in you the responsibility tomorrow onward to work hard to implement the state-of-art of the informations and the data that we have received today in dyslipidemia and osteoporosis. Remember, we are qualified family physician, qualified primary care physician. We can make the change and we can make the difference. We can protect our community and we can lead our community towards the quality of life and the well-being as well. So on your behalf, ladies and gentlemen, I would like to thank Amgen for giving us this wonderful opportunity for being here together and having these wonderful interactions and sessions. And I would like to thank our attendees online, more than 1,000 online with us. And I would like to thank also the Saudi Society for Family and Community Medicine, our warm and sweet home, where we always enjoy being a member of the society. And I would like to thank Fexus Company for providing us this wonderful organization, this wonderful place. So thank you all of you, and I wish you a very good day and a very good practice managing our patients and doing the best for the best interest of our patient. Thank you so much. Have a good day. Assalamu alaikum wa rahmatullahi wa barakatuh.